We are live now, sir. I'm sharing the screen to start the program. A very warm good evening to each and everybody present over here. On the behalf of Corona Remedies, I, Piyush Shukla, welcome you all for Corconnect live webinar series, an exclusive initiative of Banker IVF and Women's Hospital in association with Corona Remedies Private Limited. Episode 1, Pcos by Dr. Manish Banker, sir. Now, as the tradition goes, let's start the program with lamp lighting ceremony. To all the people, those who are watching this webinar through any kind of medium today, I hope you all are very aware about such an esteemed personality, Dr. Manish Banker, sir. But then also, despite he is having many great achievements, I'd like to quote some of his achievements, which make me even feel more proud while reading them. Sir, Sir is Director, Banker IVF and a Women's Hospital, awarded by the Dr. B.C. Roy Award by Medical Council of India for the year 2017. Past President ISAR 2012 to 2014, Regional Representative, International Committee for Monitoring Art, Senior Associate Editor, Journal of Human Reproductive Sciences, Member Board of Director, Posidon Group. Member Surveillance Editorial Board, IFFS 2011, 14, 17, and 20. Member Board of Director, Pacific Rim Society of Reproductive Medicines. Founder Board Member, Aspire, Member Draft Committee for Art Bill of India, ICMR, Ministry of Health, India. These are certainly very few achievements which I've mentioned. He has a lot more. And with no further delay, I'd like to welcome sir and to please take on the session forward. Very welcome, sir, on the behalf of Corona Remedies. Please proceed.
Thank you very much. It is indeed a pleasure to host this particular web series in association with Corona Remedies. And what we have decided is that we will have a series of talks on interesting and challenging infertility topics, but essentially based on what international guidelines are available. So it would be more on basis of evidence which has already been there through various international societies. I will start with the first talk on polycystic ovarian syndrome. Now, before I go into this, let us try to understand some of the terminologies which are there in most evidences. First is EBR, that is an evidence-based recommendation, which means that there is sufficient evidence available in the literature, and hence a positive recommendation is made by that particular group. A CR or a consensus recommendation is that there is still not adequate evidence, but still, based on whatever little evidence is there, it is a kind of a recommendation from the group. And a practice point is where evidence has not yet been sought, but it is still based on certain important issues which have arose on the basis of this discussion. Now, all of these are then given between 1 to 4 star, and a 4 star is the strongest recommendation or a strongest opinion, whereas 1 star is a conditional. So higher the number of stars, the stronger is the recommendation. So we will put this at the end of every subtopic based on what the evidence is. Now, polycystic ovarian syndrome was first described by Stein and Leventhal way back in 1935, so nearly 90 years back. What we know that it is a syndrome which has three essential pillars. One is the polycystic ovarian morphology of the ovary, from which it derives its name, evidence of androgen excess, and some form of oligo or anovulation. So these three are the crux for polycystic ovarian syndrome. And it is because of this, it predisposes women to a higher risk of infertility, dysfunctional uterine bleeding, obesity, and host of other metabolic disorders like diabetes, cardiovascular dyslipidemia, and hypertension, and also to endometrial carcinoma because of the unopposed secretion of estrogen. So it is a syndrome which persists throughout the life cycle of a woman, right from menarche to post-menarche, and it needs post-menopause, and hence it needs constant supervision and management. The earliest reference that we see in literature is from this reference from way back from 1721. And you can see how accurately, even 200, 300 years back, it has been described. So, young married peasant woman, moderately obese, infertile, with two larger than normal ovaries, bumpy, shiny, and whitish, just like pigeon's eggs. And you can see the photo of a heavily bearded woman. So, this description of the syndrome, even 300 years back, is pretty accurate as to how we see the condition today. But the first publication came from Stein and Leventhal in 1935, where they published a case series of 7 women who had amenorrhea, hirsutism, enlarged ovaries with multiple cysts and a thickened tunica. Again, very much similar to how we identify the syndrome today. Not only did they publish the first case series, a few years later, they also came out with a treatment option where they performed wedge resection in 47 of such women who had infertility. Out of this 47, 90% began to menstruate, so they had correction of their oligomenorrhea, and 65% of this conceived. So now we also have the first evidence of treatment of this particular condition. In the 70s, we now had the development of various radioimmunoassays where the hormones could be measured. And this was the time when clomiphene citrate was introduced into clinical practice for ovulation induction. So two important landmarks happened in 70s. Till then, ovarian wedge resection was the only option for this condition. Now, when the radioimmunoassays came into force, what it was found that the LH levels in the urine were elevated in women with polycystic ovarian syndrome. So the first evidence that some LH issue is there in women with polycystic ovarian syndrome. And we had the first publication which showed that in women with PCOS, there is inappropriate secretion of FSH and LH. And hence, it was at that point of time proposed that elevated levels of LH and testosterone are an essential prerequisite for diagnosing polycystic ovarian syndrome. So the first evidence of hyperandrogenism as an essential part of diagnosis of polycystic ovarian disease. In the 1980s, there was introduction of ultrasound and the concept of LH to FSH ratio came into force. So it was thought that not only an elevation in LH was important, but the ratio of LH and FSH was also required to be altered. Initially, people proposed 2:1, then 3:1, then 2.5:1. So various authors came out with different ratios to diagnose the condition. But eventually, this was abandoned and there was more reliance on the absolute values. However, when the diagnosis of PCOS was defined only or essentially based on LH, it was LH which became more important for confirming the diagnosis than anything else. And hence, many women who had symptoms of polycystic ovarian syndrome. They had polycystic ovaries, they had anovulation, oligo-ovulation, but in whom LH and testosterone were normal and hence they were excluded from the diagnosis. So again, this was not the correct way of diagnosing the condition. So what we have is a kind of a full spectrum. On one end of the spectrum, you have a woman who has a polycystic ovary, but has regular ovulation, has no dermatological features of hyperandrogenism, does not have insulin resistance, and is essentially a fertile woman. On the other end of the spectrum, you have a woman who has similar looking polycystic ovary, but has anovulation, menstrual disorders, hirsutism, insulin resistance. So the full-blown polycystic ovarian syndrome woman. So there is a full spectrum of women within which they would fall. Now, whether this condition would exist or not is determined by the genetic factor. So this is something which has a genetic predisposition. But at which end of the spectrum you are, whether a fertile woman to a completely infertile, has a lot to do with the lifestyle and the BMI of that woman. So someone who is obese, loses weight, can move to the left end of the spectrum, or if she gains weight, she can move to the right of the end of the spectrum. But this is not only the case, because you also have thin women with polycystic ovarian syndrome. But women do tend to fluctuate from one end to the other end of the spectrum. So the clinical presentations can vary depending on whether it is in childhood, adolescence, reproductive year, or in the postmenopausal phase. And you could have different clinical concerns and manifestations. And based on this, you need to offer them different types of treatment options. So based on all this, the diagnosis of the condition evolved from the first NIH guidelines in 1990 to the Rotterdam Consensus of 2003. Then we have the Androgen Access and the PCOS Society in 2006, the Thessaloniki Consensus on the Management, then the ESHRE ASRM Consensus, to the NIH 212 phenotypes, to finally the ESHRE 2018 and the most recent 2023 guidelines. So a lot has evolved, and PCOS is probably one condition where the pathophysiology, the diagnosis, the management concepts have evolved over a period of time based on evidence and based on newer technologies or tests and treatment options that start to get evolved into clinical practice. So I will focus this primarily on this evidence-based guideline from ESHRE in 2023. So now diagnosis and treatment of PCOS has been controversial, and as I've mentioned, it has evolved over a period of time with individual components like hyperandrogenism, insulin resistance, obesity, oligomenorrhea, PCOS, all changing over a period of time, and a great overlay of ethnic differences, because PCOS women in the Caucasian race, in the Asians, in the Far Eastern are completely different, and they have different features and different life cycles of the particular disease. But the one key feature of the three is irregular cycles and oligo-ovulation or some form of ovulatory dysfunction. So for ovulatory dysfunction, if the cycles are irregular, it is one of the key diagnostic features. Then you really don't need to look at any other criteria to define oligo-ovulation. If the cycles are highly irregular, that itself is sufficient. However, you could have ovulatory dysfunction even in the presence of regular cycles. And if that is the case, you need to carry out hormonal assessments like measuring serum progesterone, or in our country, we rely more on serial transvaginal ultrasound to look for ovulation. But how does irregular cycle or ovulatory dysfunction be defined? So important to remember that in the first year post-puberty, it is transitional. So once the woman enters into menarche or the girl enters into menarche, the first year is not relevant. Up to 3 years post-menarche, anything less than 21 or more than 45 days is considered irregular. But post 3 years of menarche, anything less than 21 or more than 35 days, or if the woman has less than 8 cycles per year, then it is considered to be irregular cycles. For adolescent PCOS, we do not need a lot of other criteria because transvaginal sonography is also difficult. And what you should do is repeated reassessments. You keep on assessing the women. And if they have symptoms, you try to treat them with symptoms. The second issue is of hyperandrogenism. Now, extreme virilization, like male pattern balding, severe hirsutism, or clitoromegaly, or full-fledged masculinization, is rare in PCOS. However, mild to moderate forms of androgen excess in the form of hirsutism, acne, and female pattern hair loss is not uncommon. And if you have these features of clinical hyperandrogenism, then you don't need to carry out any biochemical tests. So if there is hirsutism, acne, acanthosis nigricans, if you have features of hyperandrogenism, you don't need to look for any biochemical test because this itself is sufficient. So you must carefully look at the presence or absence of these clinical features. You should also use the Ferryman-Galway score because there could be ethnic variations depending on the ethnicity of the patient, and you should assign the score to be sure that the woman has hyperandrogenism or is it only a ethnic variation. Now, biochemical hyperandrogenism you start to look for only when you don't have the other two features, that is polycystic ovarian morphology or oligoovulation, and there is no clinical hyperandrogenism. Because if you have the other two features of oligoovulation and polycystic ovarian morphology, you don't need this third feature to confirm the diagnosis. However, biochemical hyperandrogenism affects a lot of women, and if you measure only testosterone, it will identify only 20 to 30% of women. But when you do the free testosterone or the unbound testosterone, you will be able to identify more than 50 to 60% of the patients. And the way to measure the free androgen index is the total testosterone divided by sex hormone binding globulin into 100, and this ratio is the free androgen index. If the woman is on an oral contraceptive pill, you should be careful because this does suppress the sex hormone binding globulins. And in that case, you should give a 3-month break of the oral contraceptive pills before you measure the hormonal levels. But again, important that you look for biochemical hyperandrogenism for diagnosis of PCOS only if the other two features are not there and you still suspect hyperandrogenism and polycystic ovarian syndrome. The third essential feature is the polycystic ovarian morphology. Now, in the Rotterdam criteria, it was defined as 12 or more follicles less than 10 millimeters in size throughout the ovary spread. So the peripheral distribution of follicles was omitted or an ovarian volume of more than 10 ml. But this has its own challenges because now we have more and more sensitive ultrasound machines which are able to pick up the follicles much better. It is also operator dependent. So there are variations depending on how skillful the operator is. So this is evolving, and with more and more sensitive machines, you are able to pick up smaller follicles more accurately. However, identification of this morphology is neither sufficient nor required if you have some other features. For example, if there is hyperandrogenism, clinical, and the woman is oligomenoric or oligoovulatory, then you need not really go into details of looking at the morphology. And the most important parameter here is the follicle number per ovary. So the number of follicles, central follicles that you are able to see in one ovary is the most important parameter. And if you have more than 20 in at least one ovary, this should be considered as a threshold for confirming PCOS. So this has gone from 12 to 20 because more and more sensitive ultrasound machines are available. So even if you see more than 20 small 2 to 9 millimeter follicles in one ovary, that is sufficient to label the patient as having polycystic ovarian morphology. So important that the patient should have two out of these three features: oligoovulation or oligomenorrhea, polycystic ovarian morphology, or clinical slash biochemical morphology. The patient need not have all the features to confirm the diagnosis. So in most patients, you should be able to come to a diagnosis based on history and clinical examination, because oligomenorrhea, oligoovulation is a clinical diagnosis, clinical hyperandrogenism is clinical, and polycystic ovarian morphology is based on ultrasound. So in a vast majority, you do not need a single blood test to confirm or to exclude polycystic ovarian syndrome. So these are the criteria for this. Now, recently, a lot of discussion is happening on the role of anti-Mullerian hormone for diagnosing polycystic ovarian syndrome. Now, this is secreted by the granulosa cells of the pre-antral and very small antral follicles. It is a hormone which prevents multifollicular recruitment. So, higher the number of antral follicles, higher is the AMH level. And because of the challenges faced with ultrasound, especially in young adolescent girls, was thought that maybe AMH might be an alternative marker for polycystic ovarian morphology. However, we still do not have very definite algorithms, and hence no specific cutoffs have been available as of now. Maybe with time, once we have more and more normograms, we should be able to use this at least as a kind of a screening marker. There is also important that these women are at long-term life risks in terms of cardiovascular disorders, and we need to put these patients under a regular surveillance to identify those at risk and initiate appropriate treatment. So they should have their lipid profiles. They should also have their annual test for endometrial thickness, hypertension, blood pressure, etc., because these patients are at much higher metabolic risk as well. Now, what about the treatment once we have come to this particular diagnosis? And the first thing that you need to focus on or give care is on lifestyle interventions, especially to those who are obese. And it has been shown in numerous studies that if the woman loses weight by as little as 5%, it does have a lot of metabolic benefits. And this is not only important in terms of infertility management, but also in terms of reducing the long-term lifestyle risks of the various metabolic syndromes. So this is something which has to be practiced from menarche till postmenopausal. Healthy lifestyle, including diet, exercise, trying to reduce central adiposity, keeping lipid profiles under check, and this should be inculcated in the lifestyle of that particular woman. What is important is at least 150 to 300 minutes of activities per week. So this is amounts to maybe about 45 minutes, 5 days in a week. And they should also try to lose weight to 5% below their current weight and try to come as close to the normal BMI that is possible. Now, what about treating non-infertility issues with this girl? So there are two things with which they would present: irregular cycles or features of hyperandrogenism. Obesity obviously would require dietary control. And the options available are the combined oral contraceptive pills, progesterone alone, or metformin. And which of the three should you give, especially to the young adolescent and adults with polycystic ovarian syndrome? Now, studies have shown that lifestyle and oral contraceptive pills help in reducing androgens. They increase the sex hormone binding globin and hence help both in regularizing the periods and also reducing features of hyperandrogenism. When you give metformin alone, either in combination with lifestyle, it reduces central obesity, but it does not enhance the overall weight reduction. So it is not a drug for reducing weight. So all studies which have compared pills with the placebo, pills with metformin, pills metformin with lifestyle, pills with anti-androgens, and there are numerous combinations and studies which have been published over the period of time. And what this guideline suggests is that the combined oral contraceptive pill should be recommended in the reproductive age for management of both hirsutism and irregular cycles. It could also be considered in young adolescent girls for their hirsutism and irregular management, and you could give either a pill with ethinyl estradiol or with low dose, typically with low dose ethinyl estradiol. Cyproterone acetate is pills containing cyproterone acetate is a second line therapy when the patient does not benefit with the conventional pills because these women are at a higher risk of venous thromboembolism. Progesterone only contraceptive pills are essentially for endometrial protection in women who are at a higher risk for endometrial malignancy. What about metformin, either alone or in combination? Is it effective in managing the hormonal and the clinical features of PCOS? Now, it is a low cost, it is easily available. We know that there is insulin resistance in women with PCOS, and metformin essentially helps by improving the insulin resistance. But the recommendation from ESHRE is that the contraceptive pills should be used over metformin in managing this. And metformin could be used only primarily for metabolic indications. So if the woman has insulin resistance in the form of either silent or overt diabetes, then metformin would make more choice. Otherwise, the pills are equally effective. What about inositol? Again, at this point of time, there is very little evidence. We still don't have sufficient evidence for introducing inositol into clinical practice. There is also some controversy regarding usage of metformin during pregnancy if a woman conceives. And we have sufficient evidence that PCOS women who conceive and are put on metformin has not been shown to prevent gestational diabetes or late miscarriages or hypertension or macrosomia. So it can be considered only in exceptional circumstances where the patient is at a high risk, not otherwise. We then move on to the main area of the talk, and that is managing infertility in a woman with polycystic ovarian syndrome. We start with identifying factors which are known to impair fertility and start correcting them. So, like correcting the weight if she is obese, try to correct or reduce smoking, alcohol consumption, sexually transmitted diseases, nutritional, so on and so forth. We should also counsel the patients that they are at a higher risk of gestational diabetes, preterm delivery, preeclampsia, and miscarriage, and hence changing lifestyle, reducing weight should be a very important, integral, and the primary part of their treatment. If this fails, we then move on to ovulation induction. And the drug of choice today are the aromatase inhibitors in the form of letrozole. This is suggested to be the first line of pharmacological treatment with very strong evidence for treating anovulatory infertility in women with a PCOS. In some countries, it is still offline, but by and large, most of the countries have recognized the use of letrozole for ovulation induction. The second choice of drug is clomiphene citrate or sometimes metformin as an insulin sensitizer. So what do the recommendations say? So that clomiphene citrate should be used in preference over metformin. So if the letrozole does not suit the patient or it does not work, then we move to clomiphene citrate. But unlike the aromatase inhibitors, the risk of multiple pregnancies is significantly higher in clomiphene citrate, and hence they need intense monitoring. The combination is only used when clomiphene alone has not worked and you do not have recourse to other options. Otherwise, the primary treatment is aromatase inhibitors, and if this fails, only then you move to the other line of drug. Inositol, either alone or along with clomiphene or aromatase inhibitors, there is very limited evidence. The side effects and the safety profile of these are not yet known, so it is not yet recommended or recommended with caution. When this primary therapy fails, we then move on to the use of various gonadotrophins, which are the second line of treatment in anovulatory women with PCOS when the oral ovulogens have failed. Now, if you look at the physiology of ovulation, what you have is an early rise of FSH in the follicular phase. Once follicular recruitment happens, the FSH starts to fall, and only the one dominant follicle which requires lower amount of FSH gets recruited, selected, and moves to dominance. In a woman with PCOS, this synchronous FSH LH secretion, it does not happen. So we need to try to mimic this. And in mimicking this, the first protocol that was proposed was the step down protocol. That is, you give a higher dose of FSH for the first few days, mimicking the early FSH rise, which happens in a natural ovulatory cycle. And once the follicle reaches dominance, that is more than 10 millimeters, you start to decrease the dose and you keep on decreasing till the day of the trigger comes in. Now, this works very well in a spontaneous cycle because of the dynamic feedback mechanism between the hypothalamus, pituitary, and the ovary. As the follicle tends to grow, it releases estradiol, which gives a negative feedback, asking the pituitary to lower the amount of FSH that is being secreted. Now, when you're giving these drugs exogenously, you do not have this dynamic feedback mechanism. So if you're too early in stepping down, you will not have follicular recruitment. If you are too late, you will have multifollicular recruitment. So even though this is something which is mimicking nature, in the absence of a feedback mechanism, this is generally not used in clinical practice. Instead, what we do is exactly the reverse. That is, we start at a lower dose and you increase the dose only if the response is not adequate. In the standard step-up protocol, what was done is 5 days of 75 international units. You monitor. If the response is good, you continue. If the response is inadequate, you increase to 150 units for another 5 days. You monitor, and so on and so forth. Now, the response depends on the threshold. The moment you are above the threshold, you will start recruiting follicles. If you're below the threshold, it will not work. And if you're too high above the threshold, you will have multifollicular recruitment. So long as the threshold of that particular woman is in multiples of 75, this will work. But for example, in this case, when the threshold is, let's say, 160, if you give 150, she will not respond, but you give 225, she will explode. So this has also its own challenges. To overcome these challenges, where where we are giving a constant dose for a period of 5 days, you have what is called the chronic low dose protocol. So what you do in this, you go slow. So you start at a lower dose, you give it for a longer period of time, and you increase it by only half an ampule. Instead of the 75 increment, you increase by 37.5, and you raise this after 7 days. So with this, it might take longer, but the risks of multifollicular development are lower. So you go slowly, you gradually keep on increasing the dose in multiples of 37.5. And the moment you are slightly above the threshold, you then maintain that particular dose. So the advantage of this is the incidence of monofollicular growth is higher. Still, you have a 30% growth of multifollicles, and the risks of multiple pregnancies and ovarian hyperstimulation are significantly lower. So this is a more safer and a more sensible protocol, but it takes a longer time to achieve it might take a longer time to achieve the threshold. So when you prescribe gonadotrophin, you must counsel the patient about the cost. It requires expertise because a lot of patients might under-respond or over-respond. You require intensive ultrasound monitoring along with hormonal assessment as and when required. You should always use a low-dose step-up protocol to maximize the the chance of monofollicular development, and you could still have implications of potential multiple pregnancies. When you use gonadotrophins, you must also define criteria for canceling cycles. And most international recommendations suggest that if there are 3 or more follicles, you should cancel the cycle because this puts the patient at a much higher risk of multiple pregnancy. Or if the response is excessive, you can convert this into an IVF all-free cycle and take advantage of the stimulation. What about laparoscopic ovarian surgery then? Laparoscopic ovarian drilling. What is being done is instead of the wedge resection, we do multiple punctures in the ovary using a electrical or a laser source, some form of energy source. Now, the purpose of the drilling is not to puncture the cysts. The puncture is to destroy the androgen producing stroma, and hence you need an energy source. You cannot do it without any energy source. The energy source destroys the stroma, it reduces the androgen production and helps improve ovulation. However, this is an invasive procedure and there is a small but definitive risk of reduced ovarian reserve, sometimes leading even to premature ovarian failure, plus the risk of adhesion formation. So we need to look at the pros and cons of this procedure and select the patient very carefully before you subject the patient to this. And you must discuss alternative treatment options like low-dose chronic step-up gonadotrophins or even IVF before you subject to this invasive surgical procedure. Now, when all of this has failed, you then have the option of in vitro fertilization or intracytoplasmic sperm injection, IVF or ICSI. In addition, it could also be the first line of treatment if there is an additional cause of infertility, for example, severe male factor along with PCOS, or if the patient is elderly and you want to move straight to IVF. IVF also has another distinct advantage that you could practically eliminate multiple pregnancies by performing elective single embryo transfer, which does not exist when you're carrying out simple ovulation induction. Now, when you're using IVF, what protocol will you use? What type of pituitary suppression would you use? The agonist long protocol or the antagonist protocol? There have been multiple studies and RCTs, a total of 8 RCTs, which have shown that there is a significant difference in the amounts of gonadotrophins required. Antagonists required lower dose. Duration of gonadotrophin, again, you need lower in the antagonist. And more importantly, a significantly lower risk of ovarian hyperstimulation in the antagonist protocol per se. The antagonist versus agonist without the trigger also has a lower risk of hyperstimulation because you are giving them a lower dose for a shorter period of time. And there is no statistical difference in the pregnancy rates or the miscarriage rates, so both are as effective. So you should also always give an antagonist protocol to a woman with polycystic ovarian syndrome. Which trigger? Now, when you're giving the antagonist, you have the option of giving the agonist or the HCG trigger. And again, studies have shown that the HCG trigger in presence of multifollicular development puts the patient at a higher risk of ovarian hyperstimulation syndrome. And in an antagonist cycle, you have the option of giving an agonist trigger for the final oocyte maturation. This option does not exist in the agonist protocol. So if you use the antagonist and the patient is at risk, you can give an agonist trigger, which would practically eliminate the risk of ovarian hyperstimulation syndrome. You do an all-free cycle and you would have equally good clinical outcomes using the frozen embryo transfer. Now, which gonadotrophin would you use for this? Urinary versus recombinant, FSH versus LH. Now, most studies have shown that both are equally good, urinary or recombinant, both have similar responses and similar outcome. So there is not sufficient evidence supporting one particular FSH preparation over the other. We also know that exogenous LH, any form of LH, should not be used routinely. A mono FSH therapy is sufficient in women with polycystic ovarian syndrome. However, in some subset of patients who do not respond well to FSH alone, you need some form of LH, either as recombinant or as a part of a HMG preparation. Is there any role of adding metformin to women who are undergoing IVF treatment? And there have been numerous studies which have shown that adjunct metformin does not improve the live birth rate, it does not lower the miscarriage rate, it does not change the number of oocytes or days of stimulation or cycle cancellation rate. So the recommendation is that adjunct metformin therapy could be used in this particular patient, but there is no very strong evidence for its particular use. Now, choice of FSH, again, you could use either urinary or recombinant, but for the trigger in an antagonist, you should use the agonist trigger and all freeze to practically eliminate the risk of ovarian hyperstimulation syndrome. And lastly, what about in vitro maturation of oocytes? Now, one of the biggest challenges and the risks of patients of PCOS is multifollicular development, cost of gonadotrophins, and the risk of ovarian hyperstimulation syndrome. So if you use in vitro maturation of oocytes, it omits the need for ovarian stimulation. You could carry out in vitro maturation and avoid hyperstimulation completely. But this technique is not available everywhere. It requires special expertise. It is not that you stimulate the patient for 5, 6, 7 days and then you do a premature retrieval. It is proper ovarian stimulation only for IVM, the trigger and the pickup of all follicles which are less than 10 millimeters. So it is not a shorter stimulation and retrieving immature eggs. It is a planned in vitro maturation egg collection without ovarian stimulation, but you could use the HCG trigger. Your clinic needs expertise to move into this particular treatment. So to summarize, the first line of treatment is lifestyle. You then move to the oral ovulogens, aromatase inhibitors, or clomiphene citrate. You could add metformin, especially in the obese or hyperandrogenic women. Second line is gonadotrophins, or you could use laparoscopic surgery, where you should weigh the risk of the surgery per se and the possible small but definite risk of reduction in ovarian reserve. And if this fails, you then move on to the most effective, that is IVF, which not only gives a higher pregnancy rate, but also practically eliminates the risks of both ovarian hyperstimulation and multiple pregnancies. So this is what the current evidence suggests for management diagnosis of polycystic ovarian syndrome. And once again, I thank you for being with us, and we have time for some questions. Thank you.
Sure, sir. It will take just 1 minute. Let me check over our Corconnect platform. Is there any question on it?
Yeah.
So for now, we don't have any such recommended question, but people are commenting that it was such a nice webinar. And Dr. Rushni Roy, she commented that she would like to hear you more in the upcoming webinars. Dr. Palak, she's saying that she's looking forward to the next series. Um, thank you so much, sir, for connecting with us today. And we also from Corona Remedies looking forward to more such upcoming webinars. And Would love to listen from you. And thank you so much, everybody, those who have connected with us over our multiple platforms. Thank you so much for having with us. And we look forward to meeting you again. Thank you so much.
Thank you very much.